All right, hello everyone, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Daria, and I'm the Global Learning Program Manager with the POCUS Certification Academy, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you may have throughout the webinar. Today's topic is Spectrum of Testicular Pathologies on Ultrasound, and our speaker is Najeebullah Durrani. Najeebullah holds a doctorate degree in medical imaging from Superior University, Lahore, Pakistan, followed by postgraduate diploma in diagnostic ultrasound from Health Services Academy, Islamabad, Pakistan. He's also an ARDMS certified in abdomen specialty. He holds membership of Ultrasound Society of Pakistan, along with several publications in different journals. We're so excited to have you, Najeebullah. Thank you so much for joining us. And if you want to turn on your camera, yes, great. Welcome, Najeebullah. We're so excited that you're here. Thank you so much. We're looking forward to your presentation.
Thank you so much, Daria. I truly appreciate your cooperation and assistance throughout this journey. I hope everybody is doing well. Nobody is sick or sad. Everybody is happy and healthy. I'm very thankful to all of you for sparing your precious time from a busy routine to attend this important webinar, which will be a spectrum of testicular pathologies on ultrasound. We have reached the time that is 9:02, so we should start presentation. Let me share my screen first. Is everybody able to see my screen?
Yes, we can see a screen.
Yeah, thank you so much.
Welcome.
So we are having here a very important topic, that the testicular pathologies on ultrasound. Before starting the presentation, let me tell you some facts about the testes. They are also called as the sperm factories. Just like an ovaries in the females, they are homologous to the ovary in female in male. So they secrete or produce testosterone, which helps to develop muscle and deepening in sound and many other important tasks. About 1,500 sperms every second. It is the work of the testes that produce the sperm, and almost 9,000 sperm every minute. Sorry, 90,000 sperm every minute. So they produce testosterone, which is a principal male sex hormone. They need 5 degrees colder to produce a sperm through a phenomena of spermatogenesis. So we are here for the spectrum of testicular pathologies on ultrasound. The topic, the title of the webinar. So the very first thing that we will go through this webinar is the scrotal anatomy. The scrotal sac consists of skin, muscle, and fibrous tissue, which is lined with parietal layer of serous membrane called the tunica vaginalis. The sac is divided in the midline by a septum or raphe. Each side contains a testis, epididymis, and a spermatic cord. The left side is lower than the right. The long axis of each testis is in a craniocaudal direction. So we are here with the layers of scrotum. From outer to inner, we have various layers of scrotum. So from outer, the very first layer of the scrotum is the fat-free skin. Number 2, the dartus muscle in superficial fascia. And number 3, external spermatic fascia. Number 4, cremasteric muscle in cremasteric fascia. Number 5, internal spermatic fascia. Number 6, tunica vaginalis. Number 7, tunica albuginea. Number 8, tunica vasculosa. And the innermost is the testes. The scrotum varies in position. It is lower with age and warm temperatures with age, and warm temperatures and higher in the young and in cold temperatures. The variable position enables the internal temperature of the testis to be kept at a level compatible with the production of sperms, which is known as the spermatogenesis. And this is the primary function of the testes. The tunica vaginalis is a membranous sac that surrounds the testicle. The parietal layer of the membrane lines the scrotal sac, whereas the visceral layer covers the testes and epididymis. The tunica vaginalis is absent posterior to the testes and epididymis. This is an important point, that the tunica vaginalis is absent posterior. And this variation makes difference in different pathologies too. We will discuss next. It's the anatomy, diagrammatic anatomy of the testes. We are having a spermatic cord with its contents, the testicular artery, pamphiniform plexus, cremasteric artery, vas deferens, and differential artery. These 5 are the contents of the spermatic cord. Then comes the retitestis in the body of the epididymis and tail of the epididymis. And on the top, on the superior fold of testis, there is the head of the epididymis and the efferentacule that are exiting seminiferous tubules, and in between the seminiferous tubule, there are the septi. Then the tunica albuginea, and the outermost is the tunica vaginalis. Well, the testicular size varies from person to person. However, the adult testes are ovoid gland measuring 3 to 5 centimeter in its length and 2 to 4 centimeter in width and 3 centimeter in anteroposterior dimension, with a volume of 15 to 20 milliliter. The testes are covered in a dense white capsule called the tunica albuginea. The mediastinum testes provides a supporting framework for the vessels and ducts entering and exiting the testes. Here we can see the 2 testes. A single testis, one is taken in a longitudinal and the second one is in transverse. So the formula for the testicular volume, we have many formulas to calculate the testicular volume. Well, the most common of them is the Lambert's or the prolates. So we take 3 measurements, the length and width on the longitudinal and the height on the transverse gain. And then we multiply these figures by a constant. Before it was a 0.51, but now it is changed to 0.71 according to the Lambert's. Why is it so? Because when you multiply the whole figures with the constant of 0.51, it can lead to the underestimation of the testicular volume. So to overcome this problem, the Lambert's had a research and published a study that if we multiply the 3 measurements with the constant of 0.71 rather than 0.51, so we can avoid a underestimation of the testicular volume. And another fact is that testicular size decreases with advancing age. Slight size difference between the 2 testes is normal. Here comes the vascular supply and the lymph drainage. The majority of the testis is supplied by the testicular artery, which is a direct branch of the abdominal aorta that enters the scrotum via spermatic cord. The cremasteric and differential arteries also run in the spermatic cord. The cremasteric artery supplies the peritesticular tissues, and the differential artery supplies the epididymis and the vas deferens. Testicular veins pass through the mediastinum as they exit the testes. The network of the veins posterior to the testis is called the pampheniform plexus, which is very important. So continuing the anatomy, the plexus of the veins accompanies the testicular, cremasteric, and differential arteries, lymphatic, nerves, difference in the spermatic cord. These are the contents of the spermatic cord. Each plexus of veins eventually forms two testicular veins, that is right and left testicular vein. The right testicular vein drains directly into the IVC, whereas the left testicular vein drains into the right, to the renal, left renal vein, a triangle. This is the anatomical variation, that the right testicular vein directly drains into the IVC, inferior vena cava, whereas if we talk about the left testicular or gonadal vein, it first drains into the left renal vein, a triangle. A triangle means at 90 degree. And then this left renal vein drain into the IVC. The primary lymph drainage of the testis and epididymis is via lymph vessels. They drain into the right lumbar lymph nodes. Well, the spermatic cords, each cord extends from inguinal canal to the posterior surface of the testis. During late gestation, the testis undescend. The testis descend from the abdominal pelvic cavity to the inguinal canal into the scrotal sac, carrying with it the testicular, cremasteric, and differential artery, and the pampheniform plexus of the veins, nerves, lymphatics, and the vas deferens. Here we can see the spermatic cord and its contents, the cremasteric muscle covering the spermatic cord, and then the ductus deferens, the pampheniform plexus, the differential artery, testicular artery. Well, here comes the technique and the preparation. Well, scrotal ultrasound is performed using linear high-frequency transducer above 7 megahertz, broadband transducer with a frequency range of 6 up to 12 megahertz or higher are preferred. The frequency range depends on the testicle size. It is better to wash scrotum with the warm water because of the dartus and the cremasteric muscle. Why to wash the scrotum with the warm water? Because the dartus and the cremasteric muscle are the strong attenuator of the incident sound beam. So they will not allow the incident sound beam to attenuate to penetrate to the testes. So that is why it is preferred in some setups at hospital to wash the scrotum with warm water to have a better skin. Well, the patient preparation, very important. Patients are usually examined in the supine position. A towel can be draped between the thighs under the scrotum, and another towel is placed over the penis. Just like that, the towel is draped under the scrotal sac, and another towel with the patient holding his penis, so that this technique does not allow the testes to move freely. They will restrict their mobility, and we know that the testes are very mobile. Warm gel should always be used as cold gel may elicit a cremasteric response resulting in scrotal thickening, thus making the skin difficult. The same thing that we should use the warm gel rather than a cold gel because it thickens the cremasteric muscle. Here comes the normal sonographic appearances. How the testis appears on ultrasound normally. On grayscale ultrasound, the normal testis has a homogeneous granular ecotexture composed of uniformly distributed medium level echos. The echogenicity of the two testes should be identical. Do remember, when there is pair, there is compare. If we are scanning the right kidney, we should compare it to the left kidney too. If we are scanning the right lobe of thyroid, we must compare with the left lobe of thyroid too. Similarly, in case of testes, if we are scanning the right testes, we should compare it with the left testes for the parenchyma, for the texture, for the size, shape, and vascularity on color Doppler 2. The mediastinum of the testis appears as a hyperechogenic band near the lateral margin of the testis that parallel the epididymis. Hello? Can everybody see me and listen to me? Hello? Hello, Daria. Yes, so here we are having the normal testes, that if we are looking for the right testes, you must look and compare the left testes too. This is normal sonographic appearance of the testes. They are homogeneous, granular throughout the testicular parenchyma. Similarly, the image on the below is showing the same, that the both testes have the same parenchyma and size, texture. There's no marked difference in their texture at all. Here comes the first pathology, which is very common, and that is the hydrocele. This is presence of an abnormal accumulation of serous fluid between the two layers of the tunica vaginalis. Do remember that the fluid accumulation or the hydrocele in the scrotal sac is between the two layers of the tunica vaginalis. I do have some MCQs at the end, so I'm emphasizing on these things so that you make sure these things, so in order you can make it correct your MCQs at the end of the webinar. It's the most common cause of scrotal swelling. It can be congenital or acquired. The acquired hydroceles may be idiopathic, caused by trauma, torsion, infarction, or associated with testicular infection or tumors. Sonographically, a hydrocele is seen as an anechoic fluid collection surrounding the testes, except posteriorly. Why? Why? Because the tunica vaginalis is absent posteriorly. That is why the fluid posteriorly will not be visible or will not be there. This is a diagram showing the hydrocele, the normal testes and hydrocele having some pressure on the testes, and the doctor, physician is draining the hydrocele to make sure relief for the patient. Here comes the first hydrocele sonographic appearances. On the left, of the top of the left image, if you can see that the right testicular scrotal sac is having a marked or moderate amount of free fluid in scrotal sac. Similarly, on the right side, you can see a mild amount of hydrocele too. And on below image, you can see that the scrotal sac having free fluid, anechoic, representing hydrocele. And if your doctor recommends or advise order for the hydrocele volume, then this is the method that how you take the hydrocele volume for the hydrocele for the free fluid. You take 3 measurements, same like you take the testicular volume. Here comes another case of hydrocele. On the left of us, there is a hydrocele, which is a simple, is not complicated or complex hydrocele. And on the right, you can see that it is a little complicated with some subtations and free fluid over it. Similarly, in this images, in the image A, the test is denoted with T, free fluid surrounding the testes. In image B, you can see the same free fluid, some severe hydrocele. And in image 3, there is a complicated or complex hydrocele with low-level internal echoes diffusely throughout the scutal sac. Well, when we put a color Doppler on a hydrocele, so we will not having any flow through the hydrocele. The testes may demonstrate a normal intratesticular vascularity. However, in the case of complicated hydrocele, there will be no vascularity at all. The second pathology is the hematoceles and the pyoceles. They are rare. They are not that much common as the hydrocele. A hematocele is an accumulation of blood in the cavity of tunica vaginalis. It may occur secondary to different scutal conditions, including trauma, surgery, neoplasms, and torsion. A pyocele is the collection of pus in the cavity of tunica vaginalis. Pyoceles results from rupture of an abscess into the existing hydrocele or directly into the space between the layers of the tunica vaginalis. Sonographically, both hematocele and pyocele appears as pertesticular complex fluid collections containing diffuse or layered echoes. They may also contain septations and appear loculated. There are no distinguishing sonographic or features or Doppler features between hematocele and pyocele. However, the clinical history is usually distinguishing. Well, the images above demonstrating the hematoceles, multiloculated, septated cystic lesions that representing the hematocele. Similarly, on the right of the screen or image, you can see the multi-septated or loculated hydrocele. You can say hydrocele or hematocele. And on the below ones, you can see the pyocele that is surrounding the right testes with low level echoes. On the right side, you can see the testes, and around it is the pyoceles. There are no distinguishing feature of ultrasound that can differentiate hematocele from pyoceles. Well, here comes the varicoceles. They're very common and very important. These are the dilated tortuous veins. The varicocele develops secondary to missing or incompetent testicular, which is internal spermatic vein valves, which then permit reflex, that is retrograde flow, resulting in dilatation of the pamphiniform plexus of the veins. They occur more frequently on the left side, most likely because of the right angle drainage of the left testicular vein into the left renal vein causes the valves to become incompetent. I have discussed this before, that why varicocele is more common on the left side rather than the right side. Varicocele are often scanned as a possible cause of male infertility. And do you know that the varicocele counts for 35 to 40% of primary male infertility, whereas 81% of secondary male infertility. So it's a big figure. If you are looking for the hydrocele, please always check the kidneys on the same side to see if a renal tumor that is invading or entering the renal vein or IVC is obstructing the drainage of the testicular vein. Retroperitoneal adenopathy may also cause varicocele due to the mass effect. Continuation of the varicocele. Sonographically, a varicocele appears as a mass of tubular structure of more than 3 mm in anteroposterior diameter along the posterior aspect of the testes. The Valsalva maneuver dilates the veins further and make the varicocele more obvious and prominent. Most varicoceles are easily diagnosed with grayscale imaging. However, from time to time, a varicocele may be difficult to distinguish from other cystic extratesticular lesions such as spermatoceles. In these cases, Doppler evaluation may help to detect the slowly flowing blood in the varicocele. The system should be optimized for low velocity flow detection and augmentation of the venous blood flow. And it can be accomplished by a Valsalva maneuver. The presence of color flow echoes confirms venous flow within the tortuous tubes. It's better to scan the patient in a standing position. There is a diagram that demonstrates the healthy veins in the testicle on the left, whereas on the right, you can see the testicle and the dilated veins in the pamphiniform plexus. They're very obvious and prominent. And if you see on ultrasound, both on grayscale and color Doppler, you will see multiple dilated, tortuous, serpiginous veins of more than 3 mm. When you put color Doppler, you can see colors flow through these veins. Well, another case of varicocele on the FVC to the image A, that the sonographer is measuring, and it's about 3 mm or 0.3 centimeter is early varicocele. And if we see to the right image, you can see there is the marked dilatation of the pamphiniform veins that is representing varicoceles. Similarly, in image B, you can see the dilated tortuous veins with color flow on it. Well, it is requested, or it is, ask the patient to have a Valsalva. You can see the difference between the Valsalva and the resting position. In the resting position, you cannot take the desired image or the desired diagnosis as compared to the Valsalva. So here is a huge difference that it supports and helps your diagnosis when the patient is advised to have a Valsalva. And another image of grayscale ultrasound, the pamphiniform plexus, the gonadal veins and the testicular veins, they are dilated, tortuous, of more than 3 mm. One more case of varicocele, you can see the posterior to the testis. There are many dilated veins representing varicocele. Here comes the spermatoceles and epididymal cysts. A spermatocele is a cyst of uncertain etiology containing cellular debris, including spermatozoa. They are usually located in the head of the epididymis. Epididymal cyst contains clear serous fluid and can arise anywhere throughout the length of the epididymis. Spermatocele and epididymal cyst have like sonographic appearances. They have similar sonographic appearances and are indistinguishable. Cysts are typically less than 1 centimeter, whereas spermatoceles have large, they are comparatively large than the head cysts. So if we see cysts are typically less than 1 centimeter, they may be unilateral or bilateral, singular or multiple, simple or spectated. Spermatoceles are more common than epididymal cysts. However, distinction is not usually clinically important. This diagram demonstrating the testicle and the 2 cysts in the head of the epididymis, and above is the spermatic cord. This is the image on the left. We're having a cystic lesion in the head of the epididymis. It's clear, no internal contents, and we put a color Doppler, so there will be no vascularity at all because cysts are truly avascular. They do not demonstrate any vascularity. In another case of epididymal head cyst, anechoic cystic lesion with no internal echoes. And on the image B, you can see the epididymal head cyst, anechoic, purely, no internal septations, no echoes. One more case of epididymal head cyst, measuring 1.2 into 1.1 centimeter with no internal echoes or septation. They're thin-lined, having posterior acoustic enhancement. Now, here comes the spermatocele. This is the difference between the epididymal head cyst and spermatocele. Well, spermatocele are multiloculated or multiseptated. So if you see here in these images, both images, you can see a multiseptations and internal echoes as well. Possibly there might be a spermatozoas. And another case of these spermatocele, multi-septated cystic lesions in the head of the epididymis, representing the spermatocele. One more, in the image D, you can see in the head of the epididymis, the cystic lesions, large cystic lesion, multi-septated with no internal echoes, representing spermatocele. Whereas in the image E, you can see a large cystic lesion with internal echoes and no vascularity. They usually did not demonstrate any vascularity on color Doppler. So this is the difference. If you found a simple cyst in the head of epididymis, they will be labeled as the epididymal head cyst. And if you are having a multiseptated, multiloculated cystic lesion in the head of the epididymis, then you are going to label as the spermatoceles. Well, the next one is the tubular ectasia of the rete testes. The dilated tubules of the rete testes can easily be distinguished from a neoplasm or vessels using Doppler. Tubular ectasia of the rete testes is not a vascular lesion. Do remember, the tubular ectasia is not a vascular lesion, and they should not demonstrate any flow on Doppler. Most of these lesions are bilateral and asymmetrical. Well, this sonogram shows a small multicystic lesion almost covering the more than half of the testicular parenchyma, representing rete testis. On color Doppler, it will be having any flow in it. In another case of rete testis, you can see at the mediastinum of the testis, there are multicystic lesions. If we put a color Doppler or power Doppler on it, so we will not be having any flow through these cystic lesions. Well, the next pathology is the epidermoid cyst. Epidermoid cyst of the testis is a benign, non-teratomatous tumor. It is often possible to make the diagnosis preoperatively, combining typical sonographic features with the normal biochemical tumor marker. Preoperative diagnosis will allow for testis-sparing surgery and prevent unnecessary radical or simple orchiectomy. On ultrasound, it is non-vascular or avascular and well-marginated intratesticular mass, may demonstrate a characteristic lamellated sign of onion skin or whorled appearance with alternating hyperechoic and hypoechoic rings. Some lesion may show a target appearance with a halo of hypoechogenicity and a central hyperechoic region. This sonogram shows a epidermoid cyst, a well-defined, rounded, solid lesion, maybe solid or cystic. It's usually they are cystic, having a lamellated onion skin appearances or sign with different hyperechoic and hypoechoic rings. Well, the image on the left, we're having a epidermoid cyst, a well-defined hypoechic lesion. And similarly, the image on the right, there is a rounded, predominantly hyperechoic lesion in the mid of the testes, representing a epidermoid cyst. They just look like an onion skin or onion lamellated. So the next one is the sperm granulomas. A sperm granuloma is a lump of extravasited sperm that forms an extratesticular inflammatory lesion, usually located adjacent to the testis or seminal vesicle. They are associated with the history of infection, trauma, or prior surgery. Sonographically, they appear as well-circumscribed, hypoechic, solid heterogeneous lesions located within the epididymis or ductus deferens. The most common location of the sperm granulomas are the epididymis. So how they appear on ultrasound? Well-circumscribed, hypoechic, solid heterogeneous lesions. Here you can see in the lower part, the tail of the epididymis, you can see a hypoechoic, well-defined, complex lesion noted. Similarly, on the right of the image, you can see an irregular, solid lesion that is extravasited sperm with variable echogenicity, representing a sperm granuloma. The epidermoorchitis, very important and very often they have after the hydrocele, the most occurrence of the epidermoorchitis is after the hydrocele. So epididymis is the inflammation of epididymitis is the inflammation of epididymis, and orchitis is the inflammation of the testes. It's responsible for the acute scrotal pain and is most commonly caused by infection. In very young children and older males, epididymitis is usually caused by urinary tract infections. Classically, the patient presents with insidious onset of pain, which increases over a period of 1 to 2 days. Fever, leukocytosis, and dysuria may also be present. These are the points that helps you to diagnose. Do remember, before starting the scan, must ask the patient for the history, because 30 to 40% of your diagnosis is done on the history base. Orchitis is inflammation of testes. In an estimated 20% of the cases, epididymitis spreads to involve the testes and is then described as epididymoorchitis. The ultrasound findings of the isolated acute epididymitis are enlarged hypoechoic epididymis associated with hydrocele and scrotal skin thickening. With epididymoorchitis, in addition to the epididymal findings, the testis is enlarged and may have focal hypoechoic areas, which, if untreated, become diffuse. It is associated with hyperemia on color Doppler that will usually significantly increase the degree of color flow seen on color Doppler in the affected person. It's a diagram demonstrating the orchitis and healthy testes. Similarly, on the right, we're having only a epididymitis, that is the inflammation of the epididymis, whereas the both testes are normal. If we look at these images, we can see that on the left, you can see a focal hypoechoic area. And when we put a power Doppler on it, it shows hyperemic vascularity, reflecting active inflammation, resulting in orchitis. I have added many images of a single pathologies, because a single pathology have multiple sonographic features. I try my best to have different sonographic features so that we can have a good eye tunes. So this is a case of a epididymitis. The epididymis is swollen, enlarged, and edematous with a reactive hydrocele. Slight scrotal wall thickness is evident. Similarly, in this image on the left, you can see the epididymis is enlarged and swollen. The image on the right, you can see the epididymis that is enlarged in size, and when we put color Doppler on it, we can have a hyperemic flow, increased blood flow throughout the epididymal parenchyma. Here comes the orchitis on the left of the image. Well, the testis, inflammation of the testis, and the role of Doppler in diagnosing the orchitis. It's very important when you use Doppler. Without Doppler, it is almost incomplete to diagnose orchitis or epididymoorchitis. So if we put a color Doppler on testes, there will be increased blood flow throughout the testicular parenchyma, representing active inflammation. Similarly, image on the right, the epididymis is swollen, enlarged, along with the testes with some reactive hydrocele, representing a epididymoorchitis. Do remember, these patients have tenderness, they are swollen, they will be experiencing pain and fever, and on CBC they will be having leukocytosis too. And another image of the orchitis, this image of the testes shows inhomogeneous parenchyma of the testes, enlarged, showing a orchitis. No color Doppler is shown in this image. And if we apply a power Doppler in case of orchitis, we can have a huge amount of vascularity. And we know that the power Doppler is 3 times more sensitive than the color Doppler. Well, the next pathology is the scrotal wall edema. Acute idiopathic scrotal edema is benign, self-limited condition of unknown etiology, characterized by ultrasound findings of edematous thickening and increased vascularity of scrotal wall with normal testicle and epididymis. Ultrasound is the imaging modality of choice in the investigation of acute scrotum. Thickening and edema of the scrotal wall, hypervascularity of the scrotum, and normal appearance of the testes are considered specific for the condition. Well, the image on the left, you can see a testes, and the arteries shows the edematous scrotal wall, a marked edema of the scrotal wall, thickening of the scrotal skin, and when we put a color Doppler on it, we will be having a good flow, increased flow. Similarly, on the image on the right, we can have both testes with minimal hydrocele and thickening of the scrotal sac, representing high scrotal wall edema, bilateral scrotal wall edema. Well, the torsion of the spermatic cord, it's very important. And it is challenging too for the sonographer or sonologist to diagnose. Torsion of the spermatic cord or testicular torsion results most commonly occurs in the neonates or adolescents. It leads to hemorrhagic infarction and necrosis of the testicle. There are 2 types of testicular torsion. Number 1, intravaginal, and number 2, extravaginal. The most common type of them is the intravaginal, that occurs around puberty, resulting in the twisting of the spermatic cord and showing or demonstrating or representing bell and clapper deformity. Extravaginal torsion most often occurs in newborns with no bell and clapper deformity. The spermatic cord and its adjacent tunica twist together as a unit as a result of a poor or absent attachment or the testis to the scrotal wall. And this diagram shows the testicular torsion, a surgical emergency which requires immediate intervention within 6 hours. The earlier the intervention, better will be the salvage rate. So the right testis is normal, whereas the left spermatic cord is torsed and resulting in ischemia. And we know that when the vascular supply is compromised, then the necrosis and ischemia occurs. Will ultrasound demonstrate large edematous spermatic cord in the image A? Will we see image B? There will be a spermatic cord which is enlarged. Normally, they do not be seen normally in the normal patient. When they caught torsion, then they become enlarged, edematous, and we can have a power Doppler with that. The vessels are circling. Similarly, in the image C, we can have a enlarged spermatic cord with a reactive hydrocele. And if we put a color Doppler on the testis, that it will be having a decreased blood flow. However, in normal patient, it has a increased blood flow. Torsion of the spermatic cord, salvage rate, the earlier the surgical detorsion can be performed, the better the salvage rate. So if you perform a surgical detorsion 6 hours or less, so there will be 80% to 100% salvage rate. And if you perform a surgical detorsion 6 to 12 hours, there will be a 70% of the survival of the testis. And if it occurs after 12 hours, so only 20% of the testis will be survived. So the earlier the surgical detorsion, better will be the salvage rate. It's an acute medical emergency. So the degree, it also depends on the degree of torsion. The degree of torsion of 360 degrees or less produces lymphatic and venous obstruction. However, arterial flow may still occur at around 360 of torsion. Arteries, they did not compress because they have thick walls, but venous flow is often obstructed. That is why it's a case of vascular congestion. Testicular torsion of 540 degree occludes the testicular artery. If the spermatic cords torsed of 540 degrees occludes the testicular artery. Here is a case of the testicular torsion or spermatic cord torsion. That the right testis, we compare the right testis with the left. So you can see that the right testis is enlarged with inhomogeneous parenchyma. And when we put a color Doppler on it, we are having no flow from the testis. But on the other hand, if we compare with the normal, there will be a normal intratesticular blood flow and normal homogeneous parenchyma of testis. And another additional point in this image is the thickening of the scrotal wall. An image of right testis, you can see there is a moderate thickening of the scrotal wall. Whereas if we see to the left, there is a normal scrotal wall thickness, and the normal scrotal wall thickness measures from 2 to 8 millimeter. Portion of the spermatic cord. Sonographically, in the acute stage, initial 6 hours, the testis is normal and sometimes enlarged and hypoechoic compared to the opposite side due to the venous congestion. A small reactive hydrocele may be present, and there may be scrotal wall thickening, as we have seen in the previous slide. In the early acute stage, day 1 to 4, there is congestion with hypoechogenicity, enlargement and liquefactive necrosis causing anechoic areas. The epididymis may be enlarged and inhomogeneous. It also affects the epididymis. Color Doppler is an invaluable tool in the diagnosis of testicular torsion. Comparison of the two testes is critical. The diagnosis of complete torsion is strongly suggested when no flow is seen in the intratesticular vessels in the affected testes compared to the normal flow in the unaffected testes. Well, on grayscale image, we can have a spermatic cord torsion, just like a cord around the neck on the top Doppler, with a small reactive hydrocele and thickening of the scrotal wall. The image A represents a spermatic cord torsion with the reactive hydrocele and thickened scrotal walls with no flow on color Doppler. Similarly, in the image B, you can see the parenchyma is disturbed and altered with some septies, and the arrows are indicating to these septies. And if we see the image C, there is a thickening of the spermatic cord, and it is even more than 0.5 centimeter. In image D, you can see a tossed testes with minimal hydrocele and thickened spermatic cord. However, the epididymis is also affected. It is enlarged and thickened. Well, these slides shows the testicular torsion, atypical appearance of the testicular torsion. Here comes the testicular microlithiasis. Intratesticular calcification is less frequently seen, has a more varied etiology, and may be associated with tumors, both benign and malignant. On ultrasound, it appears as a punctate foci of calcifications in the testicular parenchyma. Acoustic shadowing is usually not seen. There may be only a few or too many to count. It may be unilateral or bilateral, limited or diffuse. Annual sonography is usually recommended if there are additional risk factors such as infertility, testicular atrophy, or contralateral testicular malignancy. Well, on ultrasound, we can see the diffuse calcification throughout the testicular parenchyma, demonstrating a testicular microlithiasis. It is also associated with the secondary infertility to some extent. One more case of testicular microlithiasis, the arrows indicating the calcified foci within the testes. They are not casting any shadow. Diffuse testicular microlithiasis, the whole parenchyma of the testes is showing calcifications throughout the testicular parenchyma. Well, here comes the cryptorchidism, or undescended testes. The testes normally begin their descent through the inguinal canal into the scrotal sac in the 3rd trimester. Patients with undescended testes are at increased risk of infertility, testicular cancer. Even it increases to 40 or 50 folds. Seminoma is the most common tumor descent. Therefore, surgery to place the testes into the scrotum is postponed until 1 year of age. In older children and adults, the testis is surgically removed to prevent the development of the cancer. The search for an undescended testicle should begin at the scrotum and then slightly proceed up into the inguinal canal. and finally into the pelvis. They should also be examined as there an increased risk of tumor development in both the undescended and descended testes. Sonographically, the testis is demonstrated as an oval solid mass in the inguinal canal. Well, the different locations of the undescended testes, it can be intra-abdominal, inguinal, suprascutal, suprapubic, and perineal region. Due to the shortage of time, I have to go fast. So this images showed a undescended testis. This testis is trapped in the inguinal canal. With the right testis in the right inguinal canal, it is not completely descended in the right scutal sac. One more undescended testis, they're totally confined and having some mass effect. They cannot grow if they remain in the inguinal canal and can develop a malignancy. And another image of the undescended testes, image A is more obvious and prominent than the image B. When the testicular abscess, a scutal abscess refers to the collection of pus inside the scrotum. The scrotum is the sac of skin that holds the testicles. A number of factors can cause this condition to occur. It can develop as complication of untreated bacterial infection in the bladder urethra. Such infection can travel to the scrotum. As with other testicular pathology, ultrasound is the modality of choice. Sonographic feature consists of focal region of altered echogenicity, usually complex, mixed solid cystic structure, or maybe acyclic to the rest of the testis. Focal region of altered vascularity may be avascular or increased surrounding a peripheral vascularity. This diagram shows a testicular abscess. Well, if we see to the image on the left, we can see the intratesticular lesion, hypoechoic lesion of complex echogenicity, representing a testicular abscess. Similarly, image on the right, the hypoechoic, ill-defined lesion with no internal vascularity, however, increased peripheral vascularity, demonstrating intratesticular abscess. In another case of testicular abscess, when they have different sonographic features and appearances. So if you see here in the image on the left, you can see that the hypoechoic area that is with the surrounding vascularity. Similarly, image on the right, a hypoechoic area of a complex mass with no internal vascularity presenting intratesticular abscess. Let me plug in my laptop so that I could have power. Well, here comes the testicular rupture. A testicular trauma is the third most common cause of acute scrotal pain and may result in various degree of damage to the testis. Hematocele is usually present. Assess for the disruption of the tunica vaginalis. The point to be pondered and to be noticed is disruption, discontinuity, crinkling, or retraction in the tunica albuginea. These images shows a testicular rupture, which was diagnosed surgically. One more testicular rupture. Well, if we see to the image A, and the arrow is indicating to the discontinuity of the tunica albuginea, and this represents to the testicular rupture. Similarly, in the image B, you can see the disruption, crinkling, or the discontinuity in the tunica albuginea with this seminiferous tubules coming out of the testes. Same case, a little extensive and more extreme than the previous. The arrows indicating to the discontinuity of the tunica vaginalis, so that the seminiferous tubules and the testicular contents to leak out of the testes to the surrounding scrotal sac. Another case of testicular rupture. Here comes the scrotoliths. Scrotoliths are also known as the scrotal pearls. They are benign incidental extratesticular macrocalcification, not microcalcification within the scrotum. They frequently occupy the potential space of the tunica vaginalis or sinus of the epididymis. They are usually of no clinical significance at all. Usually shows a mobile hyperechoic extratesticular focus in the potential tunica space. If large enough, the pearl usually has a posterior shadow. It may be free-floating if there is accompanying hydrocele. You can see a extratesticular macrocalcification representing a scrotoliths with a strong posterior acoustic shadow. In another case of scrotoliths, having posterior acoustic shadow, multiple scrotal pearls with posterior acoustic shadow, just posterior to the epididymal head, no clinical significance. Here comes the inguinoscrotal hernias. They are usually diagnosed on the basis of clinical history and physical examination. Sonography is useful in the evaluation of atypical cases such as inguinal hernias representing as scrotal masses. The hernia may contain small bowel, colon, or omentum. Sonographically, how they appear? They appear as a heterogeneous mass is demonstrated extending from the inguinal canal to the scrotum. The mass moves and changes size with the Valsalva maneuver. The bowel shows peristalsis and the omentum appears as heterogeneous mass with echogenic and hypochromic portion. A hydrocele is often present. Images, they're demarcating the inguinal hernia. They just need a weak abdominal wall so that they can herniate through this. And another image of the inguinal hernia. Well, the image A showed a defect gap measured between the calipers, through which the small bowels omentum is herniating and protruding. Similarly, in image B, well, the image A again is a inguinoscrotal hernia with the gut loops in the scrotal sac. Image A is you can see the testes and the bowel loops in the scrotal sac. And the image B is the panoramic view of the inguinoscrotal hernia. With the scrotal tumors, sonography is extremely accurate in distinguishing intratesticular and extratesticular masses. The initial determination of scrotal mass is intratesticular or extratesticular is important because most extratesticular lesions are malignant or benign. Most extratesticular masses are benign, but the majority of intratesticular lesions are malignant. Intratesticular solid masses must be considered malignant until proved biopsy, or otherwise, testicular cancer is the number of one primary cancer affecting young men. Most testicular neoplasms are unilateral. Testicular neoplasms account for 1% to 2% of all malignant neoplasms in male. Scrotal tumors, metastasis of testicular tumors is either by hematogenous or lymphatic route, and the majority of tumors follow the regional lymphatic chain along the side of the testicular vessels. The most frequently affected peritoperitoneal lymph nodes are paracaval and para-aortic nodes at the renal hilar level. Contrast enhanced is the modality of choice for staging the testicular cancer. Tumor markers are must to advise, such as the alpha-fetoprotein, beta human chorionic gonadotrophin are helpful for the diagnosis and staging of the testicular tumors. So the germ cell tumors. It's important to recognize the two different types of germ cell tumors, namely seminomas and non-seminomatous germ cell tumors, because they have different therapeutic and prognostic outcomes. Seminoma are more radiosensitive and have more positive prognosis, whereas non-seminomatous germ cell tumors are more aggressive and subsequently have a poor prognosis. There are two types of germ cell tumors, seminomas and non-seminomatous germ cell tumors. Seminomas are the most common testicular tumor, accounting for many as 50% of the germ cell tumor. The peak incidence is the fourth and the fifth decade. Do remember, the peak incidence is the fourth and fifth decade. Seminoma are less aggressive than other testicular tumors and are usually confined within the tunica albuginea at presentation. However, some patient presents with metastasis at diagnosis. The typical sonographic appearances are well-defined, oval or round, hyperechoic homogeneous solid mass. It can be multifocal within a testis. Color Doppler vascular features are variable. However, there is usually a generalized increase in blood flow compared to normal. So both images, they are demonstrating the intratesticular seminoma. They are round, oval, irregular. And when we put a color Doppler, we will be having an increased blood flow through these solid lesions. Similarly, in the image A, you can see a hyperechoic focal rounded lesion. On color Doppler, increased peripheral vascularity. When it purely varies, whether it's a typical or atypical seminomas, they can have increased, moderate, or low vascularity. The non-seminomatous germ cell tumors are the mixed germ cell tumors, embryonal cell tumors, yolk sac tumors, teratomas, and choriocarcinoma. There are no distinguishing sonographic features between the various types. Do remember, there are no distinguishing sonographic features between the various subtypes of non-seminomatous germ cell tumors. Peak incidence is in the later part of second decade and third decade, uncommon before puberty and after age of 50. Mixed germ cell tumor is most common. Mixed germ cell tumor is the most common non-seminomatous germ cell tumors. Yolk sac tumor is typically seen in young infants and is associated with elevated levels of serum alpha fetoprotein in over 95% of the patients. Teratoma is the tumor derived from the germinal layers, endoderm, mesoderm, and ectoderm. Choriocarcinoma is associated with elevated levels of serum beta HCG, frequently resulting in the gynecomastia, which is the enlargement of the breast in these patients. These are the non-seminomatous germ cell tumors, hypoechoic, heterogeneous solid lesions. Similarly, in the image B, ill-defined complex lesion within the testes. And another image of longitudinal scan of the testis showing irregular solid lesion of inhomogeneous texture. One more non-seminomatous germ cell tumor, similar to the parenchyma of the testes. They are biopsy-based to diagnose. Histopathology is advised. Gonadal stromal cell tumors, they include the Leydig cell, Sertolise, and Granuleza cell tumors. They are rare neoplasm that are frequently hormonally active, leading to the feminizing or viralizing syndromes. There are no distinguishing sonographic features between the various subtypes of gonadal stromal tumors and non-seminomatous germ cell tumors. Clinical and sonographic characteristics of gonadal stromal cell tumors include Leydig cell tumors are most common of the gonadal stromal tumors, are usually benign and occur predominantly in men age of 20 to 50 years. Sertolise cell tumors occur with equal frequency in all age of group. Granulosa cell tumors are extremely rare. we are, I think, done with the desired time. So it's more than 1 hour. A focal lesion, small focal lesion presenting gonadal tumor cell tumor. Similarly, in these all images, the gonadal cell tumors. There comes the testicular metastasis. Malignant lymphoma is the most common secondary testicular neoplasm. Most common secondary testicular neoplasm. It accounts for 1% to 8% of all testicular tumors, and is the most common testicular tumor in males over 60 age. Still, testicular involvement occurs in only 0.3% of the patients with lymphoma. Sonographically, lymphoma and leukemia are similar in appearances. Bilateral hyperacute testis with or without enlargement. A second presentation consists of multiple focal hyperacute areas. You can see the testicular metastasis, multiple focal hyperacute areas in the testicular parenchyma, representing testicular metastasis. And thank you for your patience. Sorry for taking more time than as I was allowed. Daria, thank you for your patience too.
No worries. So that was a lot of information. Thank you so much, Najeeb, that for taking the time and presenting. We will have to probably drop our Q&A session, but we will address your questions via email. But I know Najeeb had prepared some quiz questions for you to kind of check on your knowledge and what you learned during this presentation. So I will go ahead and launch our first question that you can test your knowledge. And then Najeeb can definitely, Najeeb, are you still here? Answer or comment on the responses. Okay, perfect. Just want to make sure. So the first question you should see on the screen, and we have a couple of options. I see that about 22% of people participated. So if you want to go ahead and answer the questions on the screen. All right, I see about 25% of people participated, so I'm gonna poll and see the results. All right, we had 28% of people answered the question correctly. Najeeb, do you want to comment on why people would tend to maybe answer the first option instead of the correct answer?
Yeah, it's very easy. The extravasation of the sperm into the surrounding tissue results in a sperm granuloma. Very easy, the extravasation of the sperm. So it will be sperm granuloma. No spermatocele or varicocele or cystocele.
Great, thank you. Another question should be appearing on your screen. So let's see if you can answer the question. I see people answering. You had about 31 people answer, so about 30%. So I'll give another couple of minutes, I'm sorry, seconds to respond. We're about halfway there. So if you want to participate and answer to the quiz question, you should be able to see it on the screen. Okay, I'm gonna end the poll and share the results. I think everyone got it, almost everyone, 92%. So this is great. And then we have one more question. Okay, you should be able to see one more question on your screen. Last one. There we go. Okay, see about 70 people responded to questions. If you want to participate, feel free to answer. Okay, give another 10 seconds. Right, it was there. And here are the results. 77% got it right. So I think definitely would encourage everyone to review the recording that will be available next week. You will receive a link with the instructions on how to access the recording. You can also find the recording on our website. And I just wanted to say thank you so much to our speaker, that Najeeb. Thank you so much for joining us and having this presentation. We really appreciate it. We hope you can, join us again sometime, and I will send you all of the questions that the audience had, and we can help respond to questions. So thank you everyone for joining us today. We really appreciate your time. We know we went a little bit over time, but we hope to see you next time in our next webinar. Thank you so much. And if anyone wants to respond to our question that you see right now, did you learn anything today? Feel free to leave us any comments. Thank you again for participating. We hope to see you next time in our webinar. Thank you so much. To people who are asking about certificates, we do not issue the certificates, and we do not offer CMEs for this content. We apologize for the inconvenience. Thank you again, everyone, for participating. I see we have about 65 people online. This room will be closed in about 5 minutes. So please feel free to answer the question that you see on your screen and give us your feedback, because this is very important for our future planning.